am super grateful for the help in this. I think these are the kinds of ways that automation can make us so much better. So I will turn it over to them, and welcome back, everybody.
Okay, great. Thanks so much, Eileen. And I'm gonna apologize that I'm gonna be looking this way because I'm not sure how to move my presentation mode in front of me. So I do care about all of you, but I'm gonna be looking to the side while I share my screen. Are you seeing the presentation?
Yeah, it looks great.
Okay, perfect. So thanks so much, Eileen and Laura, for this opportunity for Randy and me to present on the Bartlett preference lists. And then we're going to go through a few HIV care related guidelines as well. Okay, so there are lots of capabilities within Epic that can help us be more efficient when we see patients and also help support evidence-based care. We're going to go through with you a Bartlett preference list that we've organized to help support your HIV primary care work in the clinic. We're also going to review smart sets and therapy plans. These are all different ways of placing orders in Epic that can help with efficiency and, again, supporting safe evidence-based patient care. Other things that are helpful to increase efficiency and promote this evidence-based care are smart phrases, the care gaps. We have an HIV synopsis in Epic, and then we also have a Bartlett dashboard. All of those things are designed to, again, help promote quality care and add to efficiencies. And then the Abridged Virtual Scribe is a new feature that we could provide some more guidance about that. I've been using it a lot, and it's very greatly helped me with my efficiency. So happy to talk to any of you more about that. But again, today we're going to be focusing on really the preference lists primarily, and then the smart sets and therapy plans. Randy and I do not have any disclosures. So we'll go through what are preference lists. We'll do some step-by-step with the preference lists and with some demonstrations. We're going to tell you about other things that we're planning for the preference lists and elicit some feedback from you all about that. Then we'll show you about smart sets and therapy plans. And again, we're going to go through some guidelines about anal cancer screening, screening for hepatitis B when you switch somebody to a nucleoside or tide sparing regimen. And then some guidelines about when to check routine HIV care labs. Okay, so what is a preference list? Preference list is something that helps organize frequently ordered tests, and it can be tailored to a clinical setting. You can organize it so that the orders that are ordered frequently by category can be grouped together. And within those groups, they can be individual orders or something called one-click, which are order panels, and we'll show you more about that. Okay, and so we're going to do some demos. I'll do a demonstration about how to follow somebody so that you can see their preference lists. So it looks like I'm doing some type of an automated forwarding. Let me see. Let me just see if I can pause it. Okay. So I'll just give you a demonstration about that. Dr. Bornmann, he is our super user for preference lists. It had been Julie MacArthur for many, many years, which was fantastic. Well, not many, many years. So we used to send you all preference lists. This was like back at the Moore Clinic day. Kristen Nolan would organize it and she would send it to you. And then more recently, Julie was our super user and you would follow her. So now Randy Bornmann has taken that over. And if you follow Randy, you're going to be following our Bartlett preference lists. So the way that you do that is you click on the list icon when you're placing orders, and then it'll pop up where you can follow users. And then you put the user you want to follow here, and then you select the person that you want to follow. So I'll give you a demonstration of that. And like I said, you're going to be following Randy. So let me pull up. I have a test patient here. Can you all still see my screen? Yes, okay. All right, so I'm going to show you how to follow somebody. So I'm in an orders only encounter. I'm going to click on this list icon. I'm going to click follow users. I'm going to look for Randy Bornmann. And then I'm going to check mark that I want to see his preference lists. You can have your own favorites as well. I have starred myself a bunch of things. I'm gonna, for the purposes of this, I'm only gonna see Randy's preference lists. So now I'm gonna have Randy take over and he's gonna go through the preference lists.
All right. Does that look okay, Joyce? Okay. So when you're in an encounter and you've already followed, like Joyce showed, you still can go to the list, list icon to bring this up. And so this is under my own name. So for me, it'd be my favorites, but for everyone else, you'd want to look at my name. And then on the left here, you can see that these are kind of different groups that we have put the orders in to try to make things a little bit faster. We've talked with the Epic people, and the Smart Set section always needs to be at the top. And we will talk more about the Smart Sets later. But in the order section, we have these groupings. So you can see we have basic HIV follow-up labs, as well as panels for a brand new diagnosis, which is more comprehensive. We have STI screening, whether the patient needs to go to Hopkins or to an outside lab. And then just to show you here, these are kind of more routine labs. We separated it for people with HIV versus in case like you're seeing someone for something else, those that are HIV negative and need STI screening. And then for individual labs, for a specific situation, those are also there to choose. We have panels for if you're seeing someone for PrEP, anal dysplasia with the anal pap, or if you need other orders, referrals, vaccines, hepatitis panel labs, nephrology, if someone has an AKI, elevated LFTs. These are just some routine prescriptions that we can add to over time that people may need to order. If a patient can't get a vaccine in the clinic, it needs to go to the pharmacy. These are just some preset prescription orders. And then these are all of the point of care tests that we're able to do in Bartlett. And so those are also quickly ordered. And then these are other things that we're just saving, and I don't have anywhere to put them, so you all will still see those. But So that's the overview. So now let me show you probably the most common thing that we'll do is if you have a patient that you're seeing for just a routine uh, uh, follow-up for HIV. So you would open the preference list and then you can go to the routine visit and let's say this patient uses Hopkins. So you'll choose this one click and then it's appended here and then you would hit accept. I do want to show you before we do this that if you want to look at the panel, you can hit this magnifying glass and you will see all of the orders that are in the panel even before you choose it. If you think that that would be helpful. And you can also see that some of the orders are pre-selected and others are not. And we will look at that. So here is the order you would choose this box if you want to have it pended, but if you want to preview it, it's the magnifying glass. So once the order is ready, you would hit accept and all of the pre-selected orders are pended, but the entire panel comes up here. So we pre-selected ones because we want to make, these are certain ones that we think most people will need. And we also, like specifically for the treponemal antibody, we want to also try to make sure that we are getting those when they're needed. So if it's inappropriate, you can unselect the viral load or the treponemal antibody if it's not appropriate. But we just wanted to have those pre-selected as kind of a reminder. For these unpre-selected ones, we also tried to add some guidance if it's needed. Like for the tropism assay, like only if you're considering Maraviroc would you need to order that, or the HLA if you're considering abacavir. So there is some guidance there, and you can select whatever you want. We'll talk later about the CD4, but that is so dependent on the patient, on how frequently it's recommended that we decided to not pre-select it. But if you do think that someone is due for CD4 monitoring, you can select it. Also, like the CBC, it's normally done whenever you do the CD4, but that's also recommended annually for people if they don't have it done for other reasons. So these are all of the selections. Something else to point out, if someone has a history of syphilis, we'd recommend unselecting the general treponemal and just selecting the RPR. This test patient does not have a history of syphilis. But if your patient does, then this alert should not be there if you want to order RPR directly. And I guess you can see all of these orders, like let's say they're due for a lipid panel. And there is a separate section for STI screening as well as anal dysplasia screening, but we just put those at the bottom. Again, the whole point of all of these is to really try to save everyone time and make things quicker to order. And to talk just a little bit more, we want to encourage everybody to update hepatitis B surface antibody annually to see if a booster is needed. So that is there with the reminder. Hepatitis C screening if should be annual, and we put for those with a risk where it should be annually, MSM, transgender women, or people who inject drugs. And so I think that is it there. So once you choose what you want to do, you hit accept and all of those orders are there. We also tried to save time. And so we, for certain orders, we did put diagnoses that we think are appropriate. If certain orders could be under different diagnoses, we did not pre-select it, like the lipid panel. So for that, you would need to choose whatever the appropriate diagnosis is to associate with that order. But for most, we tried to pre-choose those for you. I want to just point out that we did pre-select the B20 ICD-10 and chose the title of it to be HIV disease. We thought that that was the most encompassing for everyone because, there's also the Z code for like asymptomatic patients with no history of HIV related conditions. But just to kind of make things easier for everyone, we did choose this diagnosis code just to point that out. So, and you do want to only choose either B20 or the Z code for one encounter. So if you like also refilled a medicine or something, you may also see the other Z code. So you would just it's up to you. You just kind of want to choose which diagnosis because you only want to have one of those in an encounter. So then once you've associated the diagnoses, let's say you forgot, like, oh, I needed to go and check if they recently had a hepatitis B surface antibody or something like that, and you want to go back, you can just select the order panel here, and then the entire panel will be back there. So if you say, oh, it has been over a year, and I do want this now, then you can still go into that. And then if you accidentally selected something you don't want and you haven't ordered it yet, like the lipid panel, you can just choose the X right next to it to remove that. Or if you want to remove the entire panel, you can choose the X next to order panel here, and that will delete all of the orders. And then once you're ready, you can hit sign. And then all those orders will be active. So that I think is the most common panel that people will use. Now I want to show you if you go back to the preference list, you're following me, you also can select multiple things from this order at one time. So let's say someone, a week ago had abnormal LFTs, but they're also there for routine follow-up. You could choose the routine follow-up, and then you can go to the elevated LFT section and choose the panel for just mild LFT elevation. You can see we have two different order sets. So if someone's LFTs are more than 5 times the upper limit of normal, or you've already done this initial workup and did not find a diagnosis, then you can see more advanced workup in that panel. But let's say we want to do both of these just as an example. So only one of those two will open, even though the second panel here is still pended, but the HIV follow-up is what will open first. So I just want to point that out because then once you choose what you want from the HIV panel and choose accept, the second panel does not open. So you just need to remind yourself that only what was pre-selected is what is pended. So you would then need to go into the second panel and you'll see that there's additional orders that you may want in the LFT workup. And you still want to review all of these orders. It's possible that someone just had a hepatitis panel and it's unnecessary to do that. So you can, or if you choose the CMP from the HIV follow-up here, that's already ordered. You could either deselect the CMP from this preview, or once it's here, you can delete the CMP from that section so that things are not duplicated. But this is just you can either do one panel at a time and just reopen the preference list if you want to do it that way. But I just wanted to show you it is also possible to order 2 different panels at once. You just need to open the second panel yourself to see all of the orders. And then I'll show you. So here I'm deleting an entire panel at once. So another section here, let's look at anal dysplasia. So just for ease, this one is labeled 1-click for the anal pap at Hopkins, but as some of or most of you know, in Epic now you can order both the anal pap cytology and the HPV testing with a single order. So this actually is just one order, even though we just to make it look clearer and easier, it is labeled a one click. But you can see here that there's no magnifying glass to preview the anal pap at Hopkins, and that's because it is not a panel. It is just one order. Just to show you, just to remind everyone, it's the anal pap plus HPV is what that looks like. So, so that's one order that you cannot preview because it's not a panel. Other things are like here, this Mpox NAT is also like there's nothing to preview. So just to explain how everything works. And when we initially talked to everyone about anal cancer screening, they did set up an Epic that this order would work everywhere, but it ended up that there were a lot of problems. So Epic has removed LabCorp and Quest from being able to order this test to them because of all of the issues. So for LabCorp and Quest, you still need to do 2 orders, and that's what is here. So if we do LabCorp, it does the anal cytology on its own as well as the rectal HPV testing. So hopefully that will help people know which orders to do and make it easier. It's very frustrating because also for Quest, it is also different orders. So that's why Quest is separate, where it still is how we used to do it and just order the cytopathology on its own. But hopefully that will help everyone with their anal cancer screenings. And then in that same section, just to review again, there's also the referral to HRA if they need to see Dr. Grasso, the colorectal surgeon, and if they need HPV vaccine. This we did as the entire 3-dose series. So hopefully that will also help people where they could just come in and get the other ones. So does anyone have any questions at this point about actually using the order, the preference list and order panels? I know it's a lot.
Randy, it's wonderful. Steve here. This is a question not about using it, which you've explained really nicely, but one minor detail that's driven me crazy for a long time. If you go to the point of care, any one of your point of care orders, say point of care finger stick, just to double check, it's going to come up as status normal. Is that the right status for this? Because I've ordered these 100 times, it feels like, and every single time I can't sign my note later because it says this order's not done. Is it supposed to be future or status? Or future or normal? I don't know if anyone's had the same problem.
Yes, I have had that issue as well. So we did confirm that these are the orders with Sheila. We confirmed that these are the right orders. I think when that has happened to me, Steve, it's because I've chosen the wrong one because there are other options for these point of care tests. And so at least this is from my, I don't know if anyone else wants to chime in, but for me, if I order the wrong like A1C, the MAs normally will put the right order on their own, and then the one that I did is just sitting there. So hopefully that will not happen. But yes, if it in clinic, if it's the same encounter and you want the MAs to do it there, it should be normal. But if anyone is still noticing problems with that, let us know and we can try to figure it out. Because like even EKG, there's lots of different orders for EKG. So we tried to verify that these are all the ones to be able to do them in clinic.
Hey, Randy, can you
Sounds
click
great.
on the EKG one just to show? So that needs to be chosen as ancillary performed. So and that is different. So when Kristen was here, we had like a whole Bartlett EKG and it was clinic performed and they had to, it was, but now when you do ancillary performed, it goes and it gets read by cardiology. And so then the MAs are, they're uploading the EKGs that were done in clinic. They pick one. You can tell them which one you want them to do. They might do multiple, but then they'll pick one, or if there's a couple you want them to do, you can request that also. But it needs to be ancillary performed. And so Randy has that chosen correctly. Sometimes you can't close your note if the MA has not done the procedure. So they have to have done the necessary things to say that there was a point of care glucose and like put that result in. Same thing for any of those point of care tests. It requires the MA to have completed it in Epic. And so sometimes when that happens, if they haven't completed it, like that'll happen with vaccines as well. Sometimes the patient actually left and they didn't stay, in which case you would delete it. Sometimes they actually need to do it. So I will typically, when I'm trying to close my note, and it's not occurred, reach out to the MA so that they will have completed it.
Yeah, I was just going to say, Steve, I've had trouble with, you know, when I'm closing my notes at 11:58 on day 6, and then you can't because there's still this thing open. I don't think ever entered a point of care glucose because I know they can do it and they do it correctly more frequently than I do. So it's like a 2-step process anyway, where either they tell me it's in wrong and then I have to redo it, or I just tell them I would like one and then it usually happens. And I'm not being facetious. I do try, but I don't always succeed.
Same, Eileen.
Eileen, you said exactly what has been my lived experience, and I keep trying, which is why I keep getting those same blocks. And inevitably, I'm trying to sign the note at 10 o'clock at night, which Joyce means I can't go to the MA and say, "Did you complete this?" And if it's a point of care glucose, I know the number, like the deal's been done. But if there's like a billing or anything behind this that I'm afraid, I'm just going and erasing the order. So it's like, I've got a glucose value, but then it was never ordered. Oh well. But it'd be nice if the system flowed more smoothly. And yeah.
I see Sheila has her hand raised. Yes, Sheila.
Hi, so everything that you're saying is right. The MAs also then go in and make sure that the EKG has been uploaded. They keep the paper copy and they go in like a couple weeks later and make sure it's there. But if you have any concerns with the point of care testing and how to order, they really are the experts. And if you're still having issues, please let me know.
Thanks, Sheila.
Hey, this is Greg. Thanks to you, Joyce and Randy, for all of your hard work on this. I just wanted to bring up one minor also related to the issue of getting blocked out, which commonly happens to me. But this week I was trying to order a point of care glycosylated hemoglobin and having a hard time. And I feel like even in this order set, it ended up being not the one that has the word manual, but the one that has the word like integrated or something, or it's definitely a different option, but they wouldn't accept it until I could get to that option. So maybe Sheila, if you're, I mean, I could have this wrong potentially, but yeah, interfaced. I think it's interfaced is supposedly the correct one, but manual isn't, even though it's definitely linked to Randy's name and so forth. So
That's helpful, Greg. So
Should fix that and make it interfaced.
So it should be interfaced and not manual.
I
Is
think so,
that-
but yeah,
is
I
that-
never really want to go out on a limb.
Thank you, Greg, for bringing that up. Sheila, can you confirm for us what's the correct one? We'll follow up, and I think to Eileen's point,
The MA
and
say it's interface, something tells me that's the one it is. Is that what they said, Greg?
Greg is nodding his head yes. And so that's the other piece, as was suggested, the MAs can send it to you. you
Mhm.
know, and then it will be the right ones. Our apologies that, so we can fix that in the preference list. Thank you so much, Greg.
If we just, Sheila, if you could double check, just because this one does have a point of care code, whereas this is a lab code, but whatever, yeah, whatever.
I think, Randy, it might be like with the EKG, if there's some type of central system that it's going into, that might be the difference, right? So they have a point of care test, it's in the clinic and we see the result, but it maybe gets uploaded
Randy,
centrally.
send me a snip of that, please, so I can make sure with the point of care testing office
Will do.
that it's not there anymore. But if you send me that snip, I will send them an email right now.
But yeah, and Greg, thanks for playing with, using this. And I think both,
Thank you.
Randy and we really welcome feedback. So this is something that's put together to help all of us in the Bartlett Clinic. So if you find things that aren't working right or have suggestions, please let us know. One other thing I want to mention, Randy was showing you there are 2 orders that go with the anal pap for LabCorp and Quest. You only need 1 specimen. So it's 1 specimen, but then when the MAs send it off to lab, it'll go out to LabCorp or Quest. It does need the 2 orders will be on the slip for that. So, but you still only need 1 specimen to do cytology and HPV.
And then Laura asked a question just to show you the Shingrix preset. If someone needs to go to the pharmacy to get it, does have the refill for the second dose, and it's every 8 weeks. So there are special people who may need it sooner than 8 weeks, but you would have to change that. But yeah, those prescriptions to the pharmacy should be for the whole series.
And so that, Randy, this is a screen that reminds me of a pain point from months ago. You're supposed to that red warning, you're supposed to say yes, exceed that,
Yes.
yeah. So continue as is the right move there. Okay, perfect. Thank you.
And then technically the pharmacy actually doesn't need a prescription. They can do it without a prescription, but I will often print it out anyway and like hand it to the patient so that it's like an extra reminder to go over to the pharmacy. But technically it is actually not needed. David.
Well, that's my question. I feel like I guess people's experience in sending people to like get vaccines at CVS or Walgreens is not like a flu or COVID shot. Like, does that, like, Randy, if you want them to get like Prevnar 20 at CVS, because anyway, I do it because I'm at the county, we don't have vaccines. Does that work? Does the pharmacy get it? And does that help them give it? I don't know. I always struggle with how to make sure that happens.
I personally have been able to do it, and I normally you can either print it for them, like Joyce said, but I normally send it to whatever pharmacy they say. And thank you for pointing out we need to change this. I favorited this when I first came to Hopkins to make it be the Prevnar 20. So I have had pretty good success electronically sending it to their pharmacy.
Maybe I just didn't, this will help me. I think it's that outpatient order. I just never quite could figure out.
Yeah, it takes a lot of time to like find it, and like I look on UpToDate to see, because sometimes it's like dosed by milliliters, and it's like, yeah.
Well, thank you for the efforts. It'll help.
And can I just ask, like, sort of similarly, David, do you have good success in verifying receipt of those vaccines? I ask this in part because I know like Maryland has a system where we're supposed to be able to follow, and I actually, my kids have gotten their flu and COVID shots at a pharmacy the last couple of years, and I realized it wasn't pulled in, and it made me look bad. So I like queried Maryland to get their records, and they missed my daughter. I mean, I have the appointments, the verification, like in emails, but like they don't have her in their system as having received it. last year, which just made me think like, oh, how good is this system?
Yeah, I think, I mean, I use the Immunet and you have to
Yeah,
like
right.
query it and you can also look in CRISP. CRISP is the second place where sometimes the stuff that's not in Immunet will be in CRISP. There's an
Okay,
immunizations
interesting.
tab there.
Hmm.
Some of the historical stuff I've gotten from CRISP.
Okay.
But yeah, I think sometimes it doesn't. It's like if they get another practice, I think someone has to maybe actively upload it, and maybe that
Mhm.
doesn't always happen. But yeah, I don't think it's foolproof.
Yeah,
But
Eileen,
it's pretty good.
we could add to these orders. That's a good point, like a comment for the pharmacy to like please fax receipt. We could add that comment to all the vaccine orders.
I mean,
Maybe
that would be awesome. I mean, I don't know that they would do it, but and maybe it wouldn't be awesome if we got a lot of incoming faxes, but no one's getting vaccines anymore, so should be fine.
So in the interest of time, let's move on from the preference list, except I'm going to preview what we are working on. And I think, did I do the right one? No, I did not do the right share. Let me,
no, this looks good.
did it look good? Oh, okay, sorry. Okay. Okay, Randy.
Yeah, in addition to all these suggestions we've already got, we're planning to work on panels for if you're switching someone's ART to a regimen without a nucleoside or a nucleotide, or they're having viremia on treatment, a diarrhea order set, URIs, pre-op orders. But if you think of anything that you're frequently ordering and we could just make it a easy to choose panel, let us know and we'll keep, this will be a very influx thing as we get used to it.
Okay, I'm just going to quickly go through smart sets. So smart sets are, it's like a comprehensive set of orders that include labs, documentation, decision support tools, and it can have patient instructions. So I'm just going to give you a preview from Randy's preference list. Ugh. If I can move my screen over. Okay, so when you follow Randy, you can see his smart sets. As we've mentioned, his preference lists are basically everything he's favorited. You can also have your own favorites, right? So here are ones that Randy has pre-selected. And I'm just going to show an example. I have been using this pharmacotherapy for smoking cessation a good amount. And in that, in that you have a diagnosis that's pre-embedded. You have basal nicotine replacement, as needed nicotine breakthrough medications, and then additional pharmacotherapy for smoking cessation. So that's really very nice. Other smart sets, I also have, there's a diabetes management and supplies as well. There is a chronic pain one as well. And that includes, this is the chronic pain includes a note, like if you wanted to use their templated note, let me sign it and then it will show up and follow up and things like that. So I'm actually not going to spend a lot of time on this, but smart sets again can have a different combination of things. So these are ones that Randy has pre-selected that you'll be able to see. We're going to be looking at different smart sets that we think might be useful for the whole clinic to include on here. And then you can also, if you find a smart set that you like, that you want to favorite yourself, you can Just, I don't know why it's not forwarding. You can do that also. So if you find a smart set, if you right click on it, you can choose add to favorites, and that will show up as well. Okay, then there are therapy plans also, and these are different kinds of set of orders that are administered to a patient during multiple encounters at specified intervals. We can't favorite those for you to see. Randy has some favorited, but therapy plans, like when we, in order for us to be able to give the long-acting injectables, we had to create a therapy plan for cabotegravir, rilpivirine. If you're sending people to infusion in order to get iron infusion or some other infusion, those are therapy plans. So these are ones that you might want to favorite. Also, though, the nurse will send to you if you're doing Cabenuva or ibalizumab, lenacapavir, they'll send a therapy plan to you to sign.
So these are ones I have favorited that I think are good, but you can't see them. So if you want to favorite these yourself, I think that those are helpful ones.
Okay, so now we're just going to go through a few selected guidelines related to caring for people with HIV. So we're going to start with the anal cancer screening guidelines. Yeah.
And we had talked about this before. Hopefully, most of you were at that talk when the DHHS released these guidelines last year. So they separate it out in whether an HRA is available to you or not. And so since we have HRA available, you just need to follow the right side of the algorithm. And then also the starting time of when to initiate anal cancer screening in asymptomatic people with HIV. So in anyone, that should start at age 45. But in men who have sex with men and transgender women, that starts earlier at age 35. And those recommendations were based on the epidemiology of anal cancer. And so because we have HRA available, you want to ask about any symptoms of anal cancer and then collect the specimen first, the anal pap, and then after the specimen's collected, because you need to use lubricant, then you can perform the digital rectal exam. And we'll talk about how to assess it next. And if they do have any symptoms or there's abnormalities, as we'll see, then the next step of this is HRA, because the anal pap is just for screening. So was HPV co-testing performed? So now we are recommending for the future that if you're doing an anal pap to always do co-testing. But if you have old results and only cytology was done, you could still follow this algorithm until the next pap smear, whether they have normal cytology and you can repeat the anal pap in 1 year, or if they've had normals, 3 normals over 3 years, then you could wait 3 more years to repeat an anal pap smear. And if their cytology did show ascus, then you should just move forward with HRA. And then now that we are doing co-testing routinely, we are able to subtype the HPV, which is why we grayed out that area. But you can follow this algorithm on when either to repeat the anal pap or to refer for HRA. You can follow this algorithm.
Any questions about anal cancer screening before we move on? Okay. Okay, so I'm gonna just do a little overview about the importance of knowing somebody's hepatitis B virus status in general, and then in particular, if you're switching somebody from a nucleotide or side, including regimen to one that is a nucleotide or side sparing regimen. So people who have chronic hepatitis B, it being on obviously tenofovir or even any nucleotide or side, including regimen, if you switch them off, then there's an increased risk of flare. And so you both want to make sure somebody doesn't have hepatitis B infection. And then if they don't have hepatitis B, that they are immune to hepatitis B infection. So more and more we're doing these tenofovir sparing regimen, nucleotide or side sparing regimens. So in people without a history of chronic hep B infection, if you're gonna initiate or switch to one of these nucleoside or tide sparing regimens, then you should check hep B surface antigen, surface antibody, and core antibody if core antibody was never positive within 3 months prior to making that switch. If they do have chronic hep B infection and their surface antigen is positive, you must give tenofovir or entecavir. You should avoid switching to dolutegravir 3TC only 1-pill regimen because 3TC would then be the only active agent against hep B. And then you should also avoid switching to dolutegravir rilpivirine or cabrolpivirine without including an anti-hep B drug as well, again, to avoid the possibility of untreated hepatitis B infection. If somebody has isolated core antibody positivity, you could make a switch to dolutegravir 3TC or nucleotide or side sparing regimen, but this should be done with caution. So if somebody is core antibody positive, once somebody has had hepatitis B infection, there could always be the possibility of a flare if they become immunocompromised. So and you know, we have been on the more conservative side of things here, in part because of the expertise of Chloe Teo. So you know, this is doable, but again, to do so with caution and in people in whom I would suggest that you know they're going to follow up. It's unlikely that they would become immunocompromised, etc. The other thing to do is, and then finally, in people who with anti-core and anti-B surface positivity, you can switch to the nucleotide or side sparing regimen without additional anti-hep B therapy. So let's say you have somebody who's isolated core positive, but then you might want to give them Heplislav and then repeat just to ensure that their hepatitis B surface antibody is positive and they have evidence of immunity. The other thing is, it is a grade C recommendation to annually check for people their hepatitis B surface antibody status. So checking that annually, and I would say in particular for people who are on these nucleotide or side sparing regimens, do that, and then you can give a booster to help ensure their hep B immune. And we've actually run a list of people who are on nucleotide or side sparing regimens just to see where we are with knowing whether or not somebody is core antibody positive or not, if they're surface antibody positive or not. And some of you, you're going to be getting a list of your patients who we're going to recommend that you do serology testing to see their status and or to give them a Hep B booster to help ensure immunity. Let's see where we are. Okay. Any questions about this recommendation or these recommendations? Okay. All right. And then here are some additional guidelines that we'd like to review.
So these are, you can see the link here. These, the IDSA released HIV primary care guideline, or updated them last year. And this is their section on routine lab monitoring. I know there's different societies and groups that have different recommendations, but we used this recommendation mainly to help with the preference list follow-up that I showed you, like for instance, why CD4 wasn't pre-selected for everyone, because that is something that early on you would check more frequently every 3 to 6 months, but oftentimes most of our patients are in this range where their CD4 has been over 500 and suppressed for 2 years. And so it's even not strongly recommended to even continue to monitor CD4, but you could consider it, once a year perhaps when you're doing a CBC. But if you want to review this, you can go to these guidelines from IDSA and HIVMA. And just because of time, I won't go in super detail, but you can see yeah, I think we're just running out of time, but please review these if you and if you have any thoughts or suggestions about how the follow-up could be more in line with these guidelines, please let us know.
Okay, we want to give some acknowledgements. Randy Bornmann has been such an excellent partner for me to help us with quality of care, evidence-based guidelines, and just such a pleasure to work with. And then I think just doing a wonderful job in being our super user for preference lists. Ruth Howe is an ID fellow who has also been working with us as part of her QI work for her fellowship. And then Kristen and Sheila and Stephanie around the long-acting injectable work. And then Sheila, obviously, with all the all of our collaborations with the medical assistants. Julie MacArthur in her work as a super user of Epic. And then Chloe Teo for the Hep B guidance, and then Maza Abdi, Ricky Buckwald, their anal dysplasia, anal cancer screening expertise. And then Michelle Patinga is a nurse who has really helped us really expertly throughout the years for us to enhance our Epic abilities to make things easier, safer for patients, and as evidence-based as possible. Okay, so that is it for us.
Larry Chang put a comment, which Joyce and I have discussed this in blog posts multiple times. Maza and Ricky with the dysplasia clinic at Green Springs Station. I'm not sure again how many people were able to join that, but they supported the DHHS guidelines and really based on the epidemiology of anal cancer, as well as with the Anchor trial specifically about treating HSIL and preventing the development of anal cancer, which is all discussed in that post that you shared. So there's definitely possible changes in the future for what the recommendations are. We just kind of wanted to have something for the whole clinic to follow more of like a guideline committee based recommendation, but it's definitely something to think about. And Paul Sachs really did a good summary in that post.
But then he also said, how many of you can actually do this, right? How many of you actually can screen and refer to HRA and have expertise? And we have that here. So, you know, the incidence of anal cancer is increasing. The highest risk group is people with HIV and men who have sex with men. So, you know, given the increased incidence, the fact that we do have good screening, we do have the ability to follow up, we have a lot of expertise here. You know, to me, it really makes sense to follow the guidelines. There's still a lot to be learned. But Maza and Ricky, you know, we're also doing some research activities as well. So just to say, that's how I feel.
And thank you for pointing it out.
Yeah, I just put it there. I always mention I don't disagree with what we're doing at all necessarily. And I think Paul is actually coming to Hopkins soonish, I believe, and maybe a good opportunity to chat with him about some of these things.
Yeah,
People are interested.
he has one on Hep B too, like about that piece also. So yeah, yeah. Thank you, Larry.
Well, thank you, Randy and Joyce and everyone for attending. This is super helpful. And as you know, Stephanie would say if she were still here, like getting to these guidelines is not just checking boxes, it's improving equity and quality of care. So we really appreciate all of your work to make that easier for us. And everybody have a great weekend.